Well, hello. Okay, so I am Kerri Weeks. I'm a pediatrician and a child abuse pediatrician at KU. Like she said, I've been practicing in Wichita for about 10 years, and prior to that was up in Kansas City at Children's Mercy. So I've really had my entire career here in Kansas. I'm originally from Hutch, and was asked to speak today. If you notice, there was no title, I don't think, on the flyer for this talk, and it took a while to really decide what to talk about. And just tried to, elicit kind of what kind of questions were coming in from the multidisciplinary team. And there's really a lot of questions around meth and more recently, fentanyl and opiates. And so I thought I would it's a little bit of a potpourri, but I'm going to talk a little bit about methamphetamine, fentanyl, and then specifically the effects on kids, parental substance use on children, and some of the medical workup and follow-up. So this is like I said, a potpourri, so there probably will be a lot of questions. And just feel free to ask them in the chat, and I'll try to get to those. One disclaimer, it's kind of interesting. I never set out this isn't something I have been passionate about for a long time or really learned a lot about in residency and fellowship. This is something I've had to educate myself on, the whole idea of drug-endangered children and how illicit substances affect kids. Just because the population I see children with any concerns of maltreatment, and overwhelmingly the kids I see, parental substance use is a major issue, along with parental mental health, as you all know. I'm probably preaching to the choir a little bit, right? So, okay, let's see if I can advance my slides. All right, that's going to be fun. How do I advance? Okay, there we go. Nothing to disclose. So again, we're going to start with methamphetamines, then go to fentanyl and opioids, and then to vulnerable kids. So amphetamines, we're going to start with the methamphetamines first. Amphetamines is a drug class that's been around for over 5,000 years in China. The whole idea is amphetamines as a class, they bronchodilate, they help you breathe better, they help you become more alert, and they help vasoconstrict your nasal passages, help with congestion, they decrease appetite. So they really kind of help people be more alert. So back in the early 1900s, you can see that people started using amphetamines as a drug class to treat many, many things listed here, some of which we're still using this class of drugs to treat today. For example, pediatric behavioral issues, ADHD medications, many of them are in the class of amphetamines. When these first came on the market, they started to become, unfortunately, misused very quickly. The very first amphetamine on the market was a nasal inhaler, and you would sniff it up your nose and it would help with congestion. Well, people started digging the medication out of the inhaler and ingesting that, and they were noticing it was the white middle class that was doing that, and they were noticing increased violence in that community. So very early on, they realized that these drugs could be misused. And so there was a lot of restrictions put in place for amphetamines through the 70s, through the late 20th century. So, okay. So when did meth come on scene? Meth started really coming on scene in the 1960s. It was most exclusively associated with the Hells Angels and biker gangs, and they were driving it up and down the West Coast. It made its way to the Midwest, and was really responsible for, the biker gangs were still responsible for most of our meth into the 70s and 80s. Small scale labs started popping up all over the rural Midwest after that. And we now see the trend that our lab rate, the meth lab labs are going away because we're seeing a lot cheaper drugs coming up from Mexico. I want to talk a little bit about fatality associated with amphetamines, and specifically meth. Unfortunately, it's on the rise. And I just wanted to point out, and this is through 2017, that we've had a pretty drastic increase in fatalities associated with meth and other stimulants. And partially that is due to the fact that we're seeing more users with polysubstance abuse or polysubstance use. They're combining meth with opioids. And as we'll see later, opioids as a class has an extremely high risk of fatality. So you can see if you look at the dark green line, that is specifically deaths associated with psychostimulants, and an opioid. And you can just see how that curve is going up very sharply. So that's actually contributing to our deaths. Also wanted to point out that methamphetamine disproportionately affects American Indian and Alaskan natives and white folks. So this is potentially, this is a drug mostly of the Midwest, right? Midwest and South. So all of these, I really tried to look for, rates in Kansas in our local area, how many people are using this drug. And I found a lot of national data. I didn't really find any statewide data. The national data was about 0.8% of the population has used meth within the last year, 1.7 million people. And then about half of those have used within the last month. The average age of our users is about 23, but that's actually increasing. And again, that doesn't count for the really the disproportionate use in the Midwest. About 70% of our law enforcement in the Midwest is saying that meth is their worst enemy. That's the drug they're really fighting right now. So here's a little bit about meth in Kansas. What I did find was more on our labs. And you can see we've had, sorry, I do have my phone on, I'm on call. I do have, so you can see drastically how our meth labs, in 2005, we had almost 400 meth labs in Kansas, and now we're down to 3 here more recently. So, and that is really because Mexico, it's coming up from Mexico, it's much cheaper and much more pure and potent from Mexico. So that's becoming the preferred method. I will say, I just had kids brought in from a meth lab within the last month. Stepdad was making meth in the garage. So I know it still does happen and we still are seeing it. So tell a little bit about meth. So I'm gonna move some stuff around on so I can read my slides. So what are desired effects and what is meth? I'm gonna silence that baby real quick. Apologize, that's gonna happen all morning if not. So methamphetamine is a very powerful stimulant and it causes a very powerful and immediate release of dopamine. So dopamine is a neurotransmitter that flows in and out of the synapses of brain cells and nerve cells. So dopamine regulates our movement, our emotions, our reward and motivation system, and the feelings of pleasure and euphoria. So if the key that really sets meth apart from other drugs in the amphetamine class is the very powerful, immediate, huge surge of dopamine that's dumped out of the synapse. So you get a very quick response and a very powerful response of sense of pleasure and euphoria. And the desired effects, you can get quickened response time, wakefulness, increased energy, decreased appetite, increased sex drive, and just a great mood and sense of confidence. So, things we would all want, right? But here's the downside. So dopamine is typically released from the synapse and then taken back in. There's always kind of this influx and outflux of these neurotransmitters, of these chemicals. So they can kind of be reused and recycled within the nervous system. The problem with methamphetamine is it causes large amounts of dopamine to be dumped out of the synapse, but it prevents the reuptake or the influx of that dopamine back into the synapse. So the problem is you're dumping it and you're depleting it. You're not, which over time, you're depleting that feel-good chemical. You're depleting that chemical. It helps with memory, helps with attention, helps with your psychomotor speed, helps with your abstract thinking, ability to problem solve and reason, right? You're dumping that chemical. So you need more and more drug to get the same boost, right? And, and that's really one of the reasons why this drug can have prolonged and even permanent effects on someone's brain, is they're really depleting those valuable, important chemicals. So medical studies have shown that the damage to the brain from someone who's been on methamphetamine for 10 years, these looked at long-term users, was the same type of damage seen in victims of stroke and patients with Alzheimer's disease. So that limbic system part of the brain that controls emotion is significantly damaged, and that leads to a high rate of depression, anxiety in the long term, mental health issues. And that hippocampus is a part of the brain very important in memory formation, and that is damaged as well, leading to memory loss. So this is unfortunately can have prolonged and permanent damage. So these pictures have been around forever, and I put them up because it's such a visual. The gentleman on the top, the first picture, he's kind of holding it together, and the second picture is only 3 months later, right? And this, a year later for the lovely lady at the bottom. It doesn't take long for folks to go from functioning to off the cliff, not functioning with meth. Initially people, they still have some reserve of dopamine, they're holding it together. And then, once that dopamine's depleted, they really go downhill fast. And that's a big scare and risk with meth when we're talking about kids living in that environment. So what are the adverse mental health effects? Initially, when people are high on meth, they can be really restless and have trouble sleeping, hallucinations, paranoia. Again, all not good when you've got kids in the environment. Once there's a period of abstinence where they're not using, they sink into a deep depression and have trouble concentrating. And this is also when people, fall asleep for days at a time, right? When they're coming down off of these things. With chronic abuse, we see again the increase in depression, suicide attempts, and self-injury. 11 times higher rate of psychosis, which is not in your right mind. Hallucinations, paranoia, delusions. Again, this is really scary stuff when you're talking about someone who's a caregiver for a child. As far as medical complications with meth, meth can affect any organ system in the body. The big ones are cardiac, so we worry about heart attacks, arrhythmias, strokes, neurologic complications, again, stroke, seizures, long-term effects on the brain. Skin, I put these pictures up just to show if anyone has ever worked with someone who has had problems with meth use. Sometimes we'll see people that usually they're pretty skinny because they're not taking care of themselves nutritionally. And a lot of times folks will pick at their skin and have sores that then get infected. Dental, I think, is really interesting. I used to think surely there was something in meth that rotted people's teeth out. It's actually just poor dental hygiene. A lot of times, folks that use meth drink a lot of sugary beverages, again with caffeine to keep that high going, keep that sugar high going, and then they don't brush or care for their teeth. So it's literally just them not taking care of their teeth, and they rot out over time, I just think that's gross. And vision, you can actually have vision issues when the blood flow that to your eye is cut off by the vasoconstriction associated with meth. This is when we really start talking about how does this affect kids? How does this affect all areas of our community, right? And I'm going to start at the top with maternal child health. So there's an increased rate in unwanted pregnancies in women who use meth. Many of these women do not get adequate prenatal care, which can lead to poor health outcomes for the infant, increased rate of birth defects, preterm labor, so forth. Moms don't necessarily take care of themselves when they're pregnant, so their nutritional status is often poor. Again, just increasing risk on baby. They have an increased rate of HIV and STIs from using sharing needles, high-risk sexual activity, and things like that. And so this is a real concern for our pregnant moms and our providers that are trying to care for these women. In the hospital, any mom that comes in that has not had prenatal care or has had very late prenatal care, that's a red flag to us that we need to think about drug use. Community diseases really points to things like HIV and STIs. Again, high-risk sexual behaviors and other drug use go along with meth use. Environmental health, there are a lot of toxic chemicals and caustic agents that go along with small-scale meth manufacturing, and a lot of folks have kind of small scale operations going on in their home. There's, and depending on the way folks use meth, there's an increased risk of fire, explosions, kids getting into these chemicals. Most of the time, I'm just thinking of the pictures that law enforcement and DCF will often bring to me of the environments that kids are living in when parents are on meth, and it's very, very common that these are really filthy environments that are inappropriate for children, roaches and so forth. There's nobody Swiffering, right, on a regular basis. Community health really speaks to the violence, the sex trafficking, theft, gambling, prostitution, all of that tends to go along with drug use. People need to get money so they can buy their drugs. And then, methamphetamine, again, just there's an increase in violence along with that. So child abuse and violence, again, that's really where I come in. So we see with meth use and parental meth use, an increase in child physical abuse, sexual abuse, neglect, abandonment, all and witness domestic violence. These things are all in the increase, and that's how kids come to me, right? They're physically abused. They're found wandering in the street. There's a DV incident. The police go into the home, and there's these kids cowering in the corner, and and that's how I see these kids. And then looking back, yes, parental substance use and meth use is a part of that picture. And right now, I probably see over 100 kids a year. I would say in my outpatient clinic, I'm seeing at least 100 kids a year. And the grand majority of these kids have parental meth use. I would say that's the majority of the kids I'm seeing. And a lot of times they're referred to my clinic because they're found living in a home with parental meth use. I want to talk a little bit about prenatal drug exposure to meth and hopefully be able to kind of compare this a little bit to what we see with opioids and fentanyl. So with prenatal drug exposure with meth, the symptoms are at their peak or the worst, the closer they are to the exposure. So if you can think of, once they take their last hit, or baby is exposed in mom's womb and baby is born, symptoms are the worst or the most likely to be right after birth. And then the symptoms decrease over time, further and further away from that last exposure, okay? So we do watch babies closely after birth. First, any signs and symptoms of jitteriness, excessive crying or irritability, poor feeding, but babies leave the hospital now within 24 hours, pretty quick. So there oftentimes infants and moms are missed. A whole nother topic, right? But anyway, I do want to say that some of the things we do see again are the irritability and crying, jitteriness is common, and then this poor ability to self-regulate. So trouble regulating feeding, sleeping, temperature, and these things can persist for a couple of weeks. So it makes these babies hard to care for. So that's just something to think about when we're potentially sending these infants home with parents who are not at their best, potentially unable to parent because of their drug use. And we're sending a baby home that's difficult to parent, that may be more fussy, that may not feed well. So it's a setup for disaster, right? Number one cause of infant shaking, irritability, crying, right? Failure to thrive, baby not getting fed. If a baby's hard to feed, that just increases their risk. So keeping that in mind. Wanted to talk a little bit about acute meth toxicity in kids. So this is almost exclusively, I would say, in toddlers. So that is because toddlers are mobile and they're surfing the sofa and the coffee table and they're touching and they put everything in their mouth, right? So this would be the toddler that gets a big handful of something, right? Gets into the stash kind of thing. And we do see a couple of these each year. These kids present clearly with altered mental status, very, very agitated. Most of the time it's uncontrolled crying. Their vital signs, their heart rate and blood pressure are way up, and they are unable to be consoled. And someone brings them to the ER because they're so fussy, and the ED gets a UDS, and we find amphetamine class. So these kids are typically admitted to the intensive care unit for observation. There isn't any medications that we typically give them. We're really monitoring again for heart and neuro effects of seizures and signs of EKG changes and problems with their heart. But most of those resolve without us having to do anything. And actually death is pretty uncommon. The study I looked at that really illustrated this, they looked at 115 toddlers with acute meth exposure, and some of them had, about 20% of them had EKG changes that were very scary on and changes with their heart, seizures, that kind of thing, but none of them died. So I guess that's a good thing. Not that we shouldn't worry about it, but death is uncommon. I'm really more worried in the long term. My biggest concern is the chronic effects of meth on kids. And even bigger than that is the environment and the role that plays in child development. And we'll get to that a little bit later. So what are the chronic effects of meth? Meth is an appetite suppressant. So failure to thrive is common. I've also seen kids come in that are really, really overweight. And I'm wondering, the kids I've seen, I guess I wonder if usually they're the age group where they're just getting a bottle all the time. So, bottles are high calorie, and instead of, really working on age appropriate eating and activity, they're just literally, every time the baby cries, they just give them a bottle and they're just laying around drinking all the time. So I have seen kids overweight, but not necessarily getting the nutrients they need. Developmental delay is probably the biggest thing I see in my clinic. Again, meth affects brain development, right? It affects, these chemicals affect the way that the brain is wired. And so if you introduce a chemical on a regular basis, prenatally or postnatally, it can affect the way that those connections are made and affect development. So, and I think there's a huge overlap again with an environment. If you don't have a caregiver that's really attuned to that child's development and needs, that just makes the situation much worse. So behavioral, I see kids that are just like sacks of flour, that don't respond to pain, that are just don't even hardly respond to any interaction. And then we see kids that have problems with aggression and ADHD type behavioral problems that are really outwardly showing signs of behavioral issues and social struggles. So it's all over the map. These are the things that I'm seeing in clinic. I will say, in my experience, the environment the child is in has a much, much more drastic effect on these things than the drug itself. When we see kids that are essentially maybe go home with a kinship placement at birth, maybe they've had tons of prenatal exposure to meth, but they go home with a loving caregiver at birth, those kids do well. Those kids do well typically, versus kids that are in and out of the system, or not, or in a neglectful, abusive environment for months or years, and then come into care, or I see them. Unfortunately, so much damage has been done by that time. The kids I see that are actually doing well and that have been in a home with parental substance abuse, the vast majority of those have a grandparent or aunt or uncle that has been holding things together, that has been making sure the kids get to doctor's appointments, that watch the kids quite a bit, that are attuning to the child's needs. So a lot of times, and I'm sure you guys see that too, the grandparents or some other caregiver is really stepping in to pick up the slack. And those kids, actually, some of them are actually doing okay. So again, just talking a little bit about how kids ingest meth. I just want to make the point that not all through the mouth. Actually, meth can seep in through your skin. I did not realize this when I started looking into this stuff. So, toddlers, when I get hair follicle results back, I can, if I look at a sibling group, I can pretty much guess who's going to have the highest level, and it's almost always a toddler. The infants they're not mobile, right? So they're not coming into contact with all those surfaces. School-age kids are not in home all day. But the toddlers are in the home, they're on the floor, they're cuddling with the blanket, they are surfing the coffee table, and they are just soaking up every bit of that residue and putting things in their mouths. So definitely toddlers have the highest risk from what I've seen. Treatment for methamphetamine, there is no reversal agent. There is no medication that really helps with this. I think we're working on it, but it's really counseling. It's really substance abuse treatment, mental health treatment. Okay, let's see. There's already 4 things in the chat. I'm just going to pause and glance at those really quick. Make sure there's nothing. Okay, just want to make sure I'm not missing any major questions really quick before we move on. Okay, so I'm going to move on to fentanyl and opioids, and hopefully you'll be able to see a little bit of similarities and some differences in these. So a little bit on the history of opioids. They have been around forever, and most people know that they are they're a naturally occurring substance in the opium, the poppy plant. So there are opioids that are derived specifically from the plant, and then there are synthetic opioids that are made in a scientist's lab, and fentanyl is actually in the lab-made synthetic category. So opium has been around in the U.S. since before our country was born. If you look, 1776 is Independence Day. I mean, this has been around, since the beginning of our country, and was actually used during the Civil War, and many soldiers became addicted at that time. So over time, they realized the problems associated with opioids, and there was a real limitation in their use clear up into the 1990s. And this is really interesting. FDA around that time approved OxyContin for use in chronic pain. And I was in med school around this time. So I was in med school in the late 1990s. And we were taught the new thing, the revolutionary thing when I was in med school was that pain was the 5th vital sign. So, when you go to the doctor, you get your temperature, your heart rate, your breathing rate, your blood pressure taken right away. And we were taught to assess pain as the 5th vital sign right away and to treat it aggressively at the very beginning of the encounter. So it's just interesting that shift was occurring right when I was going through training, and opioids were, it was acceptable, it was encouraged, and we were supposed to aggressively treat pain. So this was just the start of the problem. As you all know, prescribing opioids has unfortunately become a huge problem in the US. So I want to talk a little bit about fentanyl. Again, fentanyl is a synthetic opioid made in the lab, and it is 25 to 50 times stronger than heroin and 50 to 100 times more potent than morphine. So it is very, very strong. It also has a quicker time to max effect. I think heroin takes about 8 minutes to reach max effect. Fentanyl is 4 minutes. So it's almost an immediate effect and very strong effect. So it came along in the 1960s, really, we use this in the OR. We use this in the operating room. So when someone's under anesthesia for surgery, we don't want them to feel anything, and we put them on a fentanyl drip. So this is a very strong pain reliever. And most of the time we're giving for someone that has a breathing tube in, right? So we're supporting all of their heart and lungs. And there's also a fentanyl patch that came out that's meant to for people with cancer and severe chronic and bone pain. That's a slow release patch. So these were very specific reasons that this drug was developed, and it has a very high abuse potential. It works stronger and it works faster. And unfortunately, there's a much higher risk for overdose death. And the increase in fentanyl being mixed in with other opioids, being laced on top of other opioids or other drugs, has drastically increased the mortality rate from opioid overdose. All right. So talking a little bit about the opioid epidemic. This is all from the U.S. Department of Health and Human Services. And there's a lot of things I just want to point out. I know it's a busy slide, but if you'll stay with me. So there's about 10 million people in this country misusing opioids. And that's 3.7% of our population. All right. The vast majority of those are people misusing prescription painkillers. We've got about 1 million people using heroin and about 270,000 people using fentanyl. So most people are using prescription painkillers. Most of these people are getting them from a doctor. They are either about a third of them, or it's a prescription that they have themselves, and the other, half or a larger portion is folks getting them out of, either buying them, just getting them handed to them, or stealing them from a family or friend. Getting them out of, getting going to grandma's medicine cabinet type of deal, or being handed them by a friend. So most of these are circulating prescription medications, and most of them have been prescribed by one doctor. So that's on us, right, as medical providers. So we still have a lot of people over prescribing opioids. You don't have to go to your dentist and the ER, multiple ERs to get pain meds anymore. Most people are getting them from one source. The good news, prescription painkillers, opioid use is actually on the decrease. Since 2018, we've had a decrease in prescribing. We've had a decrease in deaths related to prescription opioids. We've had actually a decrease in heroin initiation and heroin use in that 18 to 25 and that younger people category. So we are making headway with all the education and access to treatment. And I think there's a huge awareness now about opioids. Where we're not making headway is on fentanyl prescriptions and deaths. Deaths related to prescription opioids is down, as you can see on the right side of the screen. We're making a little headway there, but deaths to any opioid, which again I think speaks to fentanyl misuse, is up. We're still on the rise with deaths, and we're over 50,000 deaths a year now due to fentanyl. Wanted to speak a little bit about opioid deaths specifically in Kansas. So right now, about half of our overdose deaths involve opioids. The majority of those have something to do with fentanyl, either laced on top of opioids, prescription pain meds, or what have you. So we are seeing an increase in deaths in Kansas, and specifically related to opioids. I gave this talk to the folks in Harvey, Butler County yesterday, and they're seeing, I don't know what you guys are seeing, but they are seeing an increased use of opioids and prescription pain pills laced with fentanyl. People are starting to choose that over meth now, particularly pregnant women, because fentanyl is not picked up, is not necessarily picked up as fentanyl on a drug screen, and opiates are legal. So you could have a prescription for your knee pain, and it's not necessarily a red flag if you get a UDS. So it's harder to tease out that misuse, and we'll talk about that a little bit too. So what's the mechanism of action of fentanyl? Why is it so deadly and scary? Well, it targets the opioid receptor, which in the brain controls your emotion, pain, and reward. So, you get feelings of relaxation, euphoria, pain relief, which is analgesia. You can get drowsiness, confusion, nausea, constipation. Your GI system slows down, slows your breathing, respiratory suppression, and can cause you to be unconscious. So if you think it slows everything down, the big issue with that is it can cause your breathing to slow down to the point where you stop breathing. And that is the mechanism of which people are dying, it's respiratory arrest. They stop breathing. So that is the big concern with fentanyl. Wanted to talk a little bit about withdrawal. We talked about meth, from the time you have that last hit with meth, your symptoms slowly, your withdrawal symptoms and the symptoms you experience slowly decrease over time as you get further and further from that last hit. That is not the same with opioids. Opioids actually have a true withdrawal, meaning after that last hit, the further you get out from that last hit, the symptoms actually get worse, at least for a period of time before they get better. And this is the same with alcohol. Alcohol is another drug that actually has a true withdrawal. And as you may know, it can be deadly. Withdrawal from alcohol can be deadly. So it's very scary. So this makes the problem with fentanyl and these opioids is it's very, very hard to stop taking them because the withdrawal is so miserable and lasts a long time. And again, it gets worse before it gets better. So when we're looking at acute withdrawal symptoms, let's say acute in a few days after you stop using, deep muscle and bone pain, sleep problems, insomnia, sicker than a dog, diarrhea and vomiting, uncontrolled movements, severe cravings, cold flashes and goosebumps. So this is miserable. So what I'm wanting to point out here, one thing I want to point out is when we're trying to get someone off of these things, we really have to think about getting them into a treatment program that can address these withdrawal symptoms very, very fast and very early, or they don't have a strong chance of sticking with treatment and staying abstinent. They just can't take the withdrawal symptoms. So, and then after they kind of get over that peak, 7 to 10 days later, there's feelings of guilt and anger and depression and dreams of relapse and all of those things that they experience. So very, very hard to stop using. All right, I want to talk a little bit about Neonatal Abstinence Syndrome, or NAS. So NAS is actually with infant going through withdrawal symptoms after birth. When mom is using, when a pregnant woman is using opioids, baby is getting kind of a steady hit of that, right? And as soon as they're born, they are no longer being exposed to opioids, and they start to go through a withdrawal. And the signs and symptoms of that are primarily neurologic, respiratory, and GI. You can see them here, and it can be very miserable for the baby. And it can last, again, for a couple of weeks, can last quite a while, depending on mom's level of use. And so there was a huge, around 2017, 18, we were seeing more and more of this. It was really distressing to our OBs and family practice docs and pediatricians in the hospital taking care of these infants. And there's been a national push and a statewide push, specifically in Kansas, to improve the care of these moms and babies. So the KDHE helped the Kansas Perinatal Quality Collaborative do a huge project, a statewide project that went from 2018 to 2020. It just wrapped up in October of 2020. That their goal was to make Kansas the best place to have a baby, the best place to be born. And they really wanted to specifically involve birth hospitals in really good quality improvement projects, education resources to improve outcomes for these moms and babies. So before, back in the old days, if a baby was starting to have withdrawal symptoms, they would immediately whisk the baby off into the intensive care unit, away from mom, and they would, put a mask on the baby in low stimulating environment, and they'd put the baby on medication to control withdrawal symptoms. And what we were finding is that was not allowing moms to bond with their baby. It was not empowering moms, and it was also leading to long hospital stays for these babies. And so one of the evidence-based efforts is to say, okay, pharmacotherapy really needs to be reserved for babies who cannot have symptoms controlled by other means. And oh, by the way, moms can do a great job of helping assess their babies for symptoms and care for their babies during this time. So we've made a huge shift to non-pharmacological treatment. So keeping moms and babies together, doing skin to skin, helping moms keep baby in a quiet, swaddled environment. We actually are encouraging breastfeeding in moms that can. So, that helps the baby get essentially, through the breast milk, they can actually get a little bit of that opioid depending on mom's use. Certainly if we have polysubstance use going on, they probably would discourage breastfeeding. I don't know anyone if mom's on meth and cocaine and everything else, they're not going to offer that. But when it's possible, they allow moms to breastfeed, and all these things really reduce symptoms in babies. And we've saved a lot of money, a lot of hospital days, and a lot of NICU stays by doing that. I wanted to, and then babies are there for a long time, right? Again, anytime we know that this baby has a risk of NAS via mom's history or a drug test, or we see early symptoms, these babies are kept for quite a while. I think probably minimum of 5 days to a week to observe. And that allows nursing to assess mom and baby, and the medical staff to really assess their interaction and mom's behavior, and really empower and support parents. The big question always comes up, and the rub here is when do we involve DCF, right? Because opiates are legal, and if mom says, "Oh yeah, I have chronic back pain, and my doctor prescribes prescribes me my opiates," and that very well could be legitimate. So not all of these babies are certainly not all babies with NAS are due to illicit use or misuse, and teasing that out is very difficult because there's also an element of kind of privacy there, right? I mean, we don't need to go, we don't necessarily have the right to go digging through mom's past medical history and calling every provider that she's ever had to make sure that she's not misusing opiates. So a lot of it, it's a very fine line. And I would say that having these mom and baby pairs in the hospital for a long period is helpful, because it really helps us see how is mom functioning. And I would say the times that the majority of times that we end up reporting these, it's because it's clear that parents are not functioning well, mom's not functioning, and there's a risk to baby safety going home. It's not just flat out baby has NAS, it needs to be reported to authorities, if that makes sense. So unlike meth, that really doesn't have a reversal agent or a medication that you can take to help, opioid use disorder does. There's actually quite a few medications that can help. You've probably all heard of methadone. Methadone is in itself an opioid. So the key with methadone is it is a long-acting opioid. So instead of getting that huge, powerful dopamine release or opioid, wrong drug. Instead of getting that huge, powerful, euphoric feeling from meth, Kerri, second time, from your opioid, those opioid receptors, it's a low and slow. So you kind of have this low-grade, long-term, release. And that's helpful because it helps with withdrawal symptoms, it helps reduce cravings, and it actually blunts the response of other opioids. So it kind of blocks all those receptors, so you don't get the same hit if you use or misuse other opioids. The key with this is you have to get it through a treatment program, and you have to be under the very close watch of a treatment program when you're on methadone. Buprenorphine is very similar. It's a partial agonist, opioid agonist, so not quite as powerful as methadone, but it can be prescribed. The key with this is it can be prescribed by any physician that has a waiver. So potentially, the goal is to increase access to care. So family doctors and other folks that feel comfortable and confident and have gone through training and have a waiver can prescribe this for their patients. And it's really an effort to increase access to care. Naltrexone is cool. It blocks the effects of opiates. So it's not addictive. You don't go through withdrawal. It simply just blocks receptors. So you don't get the same hit or same effects when you take opioids. The problem, this is great when you're trying to get to help people remain abstinent from opioids. The problem is if you stop taking it and you relapse, it actually can lower your threshold for overdose. So, if you needed a very high level or you're at a point where you're taking a ton of opioids and you needed a high level of opioids just to overdose or have that respiratory compromise or breathing problems. Now, maybe the level you actually, the level's much lower. So if you relapse and take that same high level of drug again, you have an increased risk of an overdose. That makes sense. So that can be dangerous. The one that you guys are all probably familiar with, or I hope you are, is naloxone, which is Narcan, and that is an immediate reversal. It has immediate reversal effects. So this is the nasal spray that really many communities are trying to get in the hands of first responders. Oh wow, 10 minutes out. Okay, good to know. We're trying to get this in the hands of first responders so that when they go out, even before they get to the hospital, they can, if they see someone that they think may have an overdose, an opioid overdose, they can sniff this up their nose and already starts to restore their breathing. So again, just comparison of the two, I think of methamphetamine as speeding up the body, kind of Tasmanian devil, and fentanyl is kind of slowing down the body, right? That's a happy sloth. I was trying to find like a stoned out looking sloth or a happy sloth, but I don't know, sloth kind of made me think of a sloth for some reason. With methamphetamine, we have less users and less deaths. Opioids, definitely more users and more deaths. With meth, you're going to have agitation, confusion, and violence, and all the public health concerns that come along with illicit substance use, and specifically child maltreatment, the risk of child maltreatment in a home with meth use. With opioids, I personally haven't seen, and I didn't see any studies that specifically talked about increase in physical abuse with parents on opioids. The studies that I looked at really talked more about just parental disengagement and neglect, right? If you are zoned out, you are, you're less likely to be engaging in that and helping with that child development, and neglect, lack of supervision, safety issues become more concerning. I personally, I haven't seen an influx of children into my clinic due to parental opioid misuse or abuse yet. Unfortunately, with the increase in adult deaths, in the wake of those deaths are children, right? So that's that we are seeing that. Okay, I don't have a lot of time, so I'm going to kind of speed up a little bit. Just wanted to make the point that polysubstance abuse is super common, almost ubiquitous, and unfortunately, the combo of meth and opioids is growing. It's growing in our community, and it's increasing overdose. So that's also just wanted to make a point. Again, I'm probably preaching to the choir. Just the high level of mental health problems associated with substance use disorder, and the lack of treatment, or the amount of people that aren't in treatment. This is just such a telling slide to me. Of 20 million people with substance use disorder in our country, 90% of them are not getting treatment. People with mental illness, almost 10 million people with substance use disorder and mental illness, 90% of them are not getting treatment. So just keeping that in mind. When you see substance use, parental substance abuse, you need to be thinking mental health. Mental health, those are going hand in hand, because we all know that people often use substances because they, people are higher risk that have had a traumatic childhood or have are trying to self-medicate a mental health issue. Okay, let's see. I'm going to try to keep my eye on the time here. Maybe I should stop there and see where we are in the chat. Actually, Deanna, would you want to? Okay, here we go.
We do have a few questions. One of them specifically, a couple of them are interested if we could get the slides, if you could do the PDF version of the slides to make available for them.
Yes, I can. I can send this to you guys. And how long does sepsis take? Meconium, I do have one on, let's get to that slide. This is talking about the developing brain and just how important, most of your brain development is for age 5. So it's important that we're getting these kids into a healthy environment early. The hierarchy of needs, and I just want to point out that, you have to have your physiologic needs met as a child, fed, clothed, safety, supervision. But a huge part of becoming a functional adult is getting to the yellow zone, getting to the love and belonging needs. There's so many kids that aren't getting there. And I think it's really hard for kids that are in homes with parental substance abuse to get to those higher levels of their needs being met. And a lot of them aren't getting the bottom 2 rungs met. And that's just pointing that out. Neglect is by far the most common thing we're seeing and can be more deadly than physical abuse. And this is just to illustrate the cycle of abuse, substance use, and mental and physical health problems. We all know this, right? It's a cycle. You know, parents that struggle with this as kids are struggling with this as parents, and it's just a cycle that goes around. Okay, let me see if I can get to, I will get to the hair follicle thing here in a minute. Just wanted to, this is an important slide. If you are coming across a child that you see is just not right, having neurological symptoms, they are not focusing, they are crying, they are throwing a tantrum, they are inconsolable, they're jittery, they need to have immediate medical attention. If you see if you're going into a home and you see visible injuries on a young child, pattern injuries, injuries to their ears, their neck, their torso, those are kids that need to be seen right away. If you find a kid in a lab, they need to be seen right away. And those kids that are found wandering, which we see all the time, usually parents are passed out somewhere, need to be seen right away. In my outpatient clinic, I try to see every kid under 3, just because they're so much more vulnerable to physical injuries that we can't see. I'm really worried about their growth and development. Again, majority of that brain development is happening early in life, and most of those are nonverbal, and they can't tell us what's been going on and what hurts. A lot of times when I get referrals, older children, school-age children, I'll refer back to their primary doctor because I feel like it's more important for them to get that holistic approach and continuity of care from their primary doctor. So if you refer kids to me and you're like, why did you see that kid versus that kid? That's why. But the youngest kids need to be seen, universally need to be seen. And I like them to be seen in my clinic or the ER if is a last resort if I'm out on vacation or unavailable, and they need to be seen quickly. Just to address the meconium question, it gives you about a 6-month window. So meconium starts collecting, which is baby's first poop, right? So that early in that 2nd trimester, meconium is hard to test. We do send it, but sometimes it's, mom throws away the diaper. It's hard to, I've just seen a lot of variable results of meconium. Blood and urine tests just give you a very short window and honestly aren't super helpful unless it's in the context of an acute intoxication. Urine drug screens also have a pretty high threshold for popping positive. So if the level is there but low, it may not pop up positive. And with kids, that's important. Like if it's there at all, like we need to know, right? So I'm not a huge fan of EDS unless the child is clearly intoxicated. Hair follicle is the way to go. It takes about 1 week for a substance to grow out in hair, and it gives you about a 90-day window. So the key with hair is the lab actually washes the hair and it tests for the metabolites of the hair in the hair. So you actually have to ingest the drug and grow out the metabolites in your hair for the hair follicle to be positive. So it's actually, I like it because I feel like it's reliable. It gives you the metabolites, so there's a lot less, oh, I had a poppy seed muffin for breakfast. I mean, it really gives you more specific drugs, and it gives you a nice window of time of exposure. Key things to know about hair follicle testing. If you've had one exposure to a substance in the last 90 days, it's very unlikely you're going to have a positive hair follicle. I mean, I've had parents say, oh, we went and played at the park last week, and we think people do meth on this park bench that we sat on for a few minutes. And no. And you need to have more than one exposure for it to become positive. And again, it's very uncommon to have a false positive. What we can't say is exactly when or where or who they were exposed. It's a window of time, right? And I really interpret the numbers with caution. I mean, if you took a patch on this side of the kid's head and a patch on this side of the kid's head on the same day and tested them, you're likely to get two different numbers. I mean, the fact that the drug is there is important, but the level isn't as important to me. And that has so much to do with the size of the child and their hair. And so just keeping that in mind. Let's see. Just make sure I'm getting, okay, I think I'm coming close to the end. If anyone wants to unmute and ask any or last minute questions, I will take them in the chat, or you can just unmute. This is really toward the end. I just wanted to point out that the best thing for these kiddos, it's not a one size fits all. You look at any child that's been exposed to a substance, you look at, it's not that they don't need services, or, there's not a stamp of you're going to have problems. There's a huge variety of ways these kids present, and a huge variety of level of functioning and impairment that they have. And you really just need to treat the symptoms that they're exhibiting. And the majority of that's happening in the home, right? Being in a nurturing, calm, loving home with routine, and someone who's just addressing their needs, right? So going to physical therapy or play therapy once a week is good, but it's really where they're living, and the person that's day to day looking them in the eyes and giving them that serve and return nurturance is really the most important thing. So I think with that, that's all I have. Let me get to my
Thanks, Kerri. It is 11 o'clock, so anybody that needs to leave, I know they've been kind of jumping off as needed. It was scheduled till 11. So if you do need to go, just thank you so much for being here. Thanks, Kerri, for that great presentation and all that wonderful information. We do have a few questions in the chat. So if those people want to stick around, and if Kerri can stay an extra few minutes, I'm going to stop recording. And Kerri, I'll leave that up to you.
Okay, I'm